wonderful experience of hybrid presentation between in-house presentation and online presentation. I guess we are heading to a wonderful night, sharing good quality of knowledge for the day. It's my pleasure today to welcome you here on behalf of Sudan Heart Society and for our hosting Alwali company and Novartis company. As also is great enthusiasm, and we're going to have today our talk based only on a syndrome that affects about 1 to 2% of population worldwide, and in fact about 10% more than 70 years old population worldwide, and that costs and drains the health service worldwide. It's not our only problem. Heart failure is the problem of the whole world. Without further ado, I'm going to present my friend Yagoub. Yagoub Marzouk is well known to all of us here as one of our eminent cardiologists, special interest in heart failure. He's an interventional cardiologist, and he's currently the co-chair for the Pan-African Heart Failure Lead. Yagoub is going to share with us the experience of heart failure throughout Africa. And the floor is yours, Yagoub. Welcome. It's nice to hear you once more. Thank you.
Thank you. Thank you, Sadiq Askar, for the warm welcoming. It is my pleasure again to see all of you here. And it is always a good moment to be in Sudan, even though through this online environment. So can I share my screen?
شير طوال يا دكتور.
I am sharing or not?
You're not sharing yet.
Still not? I am not a co-host, so you need to make me a co-host so I can share, I think.
Start sharing. Victor?
Yes?
Start sharing.
I am sharing now. Is that clear or not projecting?
It's not projecting.
Allow participants to share screen. Allow participants. Allow participants to. Participants. On. انت عامل ستوب للشغل.
في البروجكشن في اوبشن بتاع multiple participants can share. هسه بيجيك ثاني يتعاملوا على اساس واحد ما في زول بروجكتنج.
أنا ما عم شير لسه. Victor?
Yes.
Dr. Yagoub, can you unshare and share again, maybe?
Yeah,
you're
now
already a co.
I am unshare and trying to share again.
Okay.
Should be easy.
كده في share screen there. multiple participants. لا لا ارجع لأرجع. multiple participants can change. ايوه
يلا ده ما كده ما تشيل فهو عادي هنا ممكن تشيل.
اي لكن
Sharing now?
still nothing yet والله.
Yeah, before was sharing. Now? Things should be okay.
انا شفتها
شيل.
تمام. You can see it very clear.
Okay, so hello guys. Okay, so good night everyone. Eid Mubarak, كل سنة وانتم طيبين. It is always a good pleasure to be with you. My task is to speak about burden of heart failure in Africa and Sudan. But as you can see from the title, I just make it in Sudan for many purposes. One of them that I felt it is really it's good chance to have a good look into what's the data we have in Sudan. And other reason, for the sake of time, it is only 15 minutes, so I don't want to make it long. So I will be speaking about what is burden in terms of epidemiology, as well as clinical outcomes. And at the end, I will share some thought about what I believe is the ways forward. So when we speak about epidemiological burden of heart failure, then one cannot speak about this without mentioning a very essential paper published by our dear friend and colleague Ahmed Ali Sulaiman in 2011. That paper, he spoke about the state of heart disease in Sudan. This paper was mainly, the data mainly obtained from the Sudan Household Survey conducted in 2006, plus stepwise survey and other published literature. But the main source of the data presented by Ahmed Sulaiman in this paper was the Sudan Household Survey conducted in 2006. That survey actually involved like 25,000 households and over 50,000 Sudanese people have been interviewed. So it, as you know, survey means just you is questionnaire and you fill many questions about that. The conclusion of what Ahmed Ali mentioned in this paper, that is heart disease is prevalent in Sudan with at least 2.5 of the population affected. And remember, this is 2.5% of heart disease in Sudan is self-reported. So they just ask everyone, do you have heart disease or not? If the respondent mention he or she has heart disease, then they will take this one has heart disease. So the self-reported heart disease is 2.5. This is in that survey in 2006, which is quite low compared with what quoted in other countries and other parts of the world. But anyway, this remains one of the main paper published in this regard. The important point I would like to draw attention, that is what he wrote at the end, that the rate of hypertensive heart disease, ischemic heart disease, rheumatic heart disease, and cardiomyopathy constitutes the bulk of heart disease. So the bulk of heart disease is hypertensive, ischemic, rheumatic, and cardiomyopathy. And of course, it is easy for everyone to guess that this is the main factor contributing to heart failure. So if the main bulk of heart disease in Sudan is these four diseases as hypertensive, ischemic, rheumatic, and cardiomyopathy, then one can easily guess that is heart failure indirectly is quite prevalent in Sudan. Again, Ahmed Ali himself published a paper in Sudan Medical Journal in 2011 as well, speaking about burden of heart disease at Shab Teaching Hospital. And this data is, he presented the data about total admission at the Shab Hospital from June to December 2009, so over 6 months. I believe it's like 1,500 patients, the total number of patients. And the whole admission, all admission, included in that study, he looked into the pattern of the disease and the diagnosis of the disease. And I have just to mention that is a single patient could have more than one diagnosis. So patient can have diagnosis of ACS and heart failure, and or ACS and arrhythmia. So one patient could have more than one diagnosis, and I believe this is one of the weak point of this or deep picture. But anyway, this is a retrospective study, and we can appreciate how difficult it is to look at the data respectively in our hospital and in Shab Teaching Hospital. But nevertheless, this was very great job done by Ahmad Ali Sulaiman. And as you can see, in the middle here is the CCU, and if you could see here in blue, 73% of patients admitted to CCU were due to ACS, which is quite understandable, and 47% of patients admitted to CCU were due to heart failure, acute heart failure, I mean. Compared to patients admitted in the ward, you can see that is 86% of patients who admitted to the ward were due to acute heart failure or acute decompensating heart failure, while 20% were due to acute coronary syndrome. Making the whole picture that is 71% of patients admitted to Shab Hospital at that time were due to acute decompensating heart failure, while 47 are due to ACS, 63 due to arrhythmia, and 3.3 due to others, and 3 due to infected endocarditis. Making acute decompensating heart failure is the largest patient category admitted to Shab Hospital in 6 months. And this also, it gives us some clue about how relevant heart failure and what is the burden in terms of epidemiology we are facing. Nevertheless, Shab Teaching Hospital is a tertiary hospital, so one can understand that is many patients admitted to the hospital are terminal and or already diagnosed with heart disease, so some bias regarding type of patient admitted to the hospital is there. This is one of the relatively good paper also published by a group of Sudanese doctor, Ahmed Al-Mubarak, Haytham Awadallah, Muttaba Usman, Mohammed Ahmed. None of them is cardiologist. They work in different hospitals. Some of them were in KSA at that time, but nevertheless, they look at the prevalence and predictive factors for heart failure among Sudanese individuals with diabetes. So they look at diabetic patient and what is the prevalence of heart failure and what is the predictive factor for heart failure. They call it a population-based survey. So one can guess it is a population-based, but when you go into the details, it was actually a hospital-based. But nevertheless, they look at diabetic patient who admitted to 3 hospitals in Khartoum without cardiovascular disease, I believe, and they look what is the prevalence and predictor of heart failure among these patients. So they included more than 300 patients, and this is their conclusion. That is the prevalence of heart failure estimated to be 12.06% among Sudanese individuals with diabetes. And we all know diabetic have at least 2-fold increase in heart failure compared with non-diabetic. So it gives us a clue also about how prevalent heart failure in our community. So it's 12% in diabetic patient, and this is more or less in line with what you will face in much of the literature. That is, diabetic patient have like 10 to 14 or 15% prevalence of heart failure. And I mentioned that the risk factor are hypertension and cholesterol, and when they did adjustment, hypertension was the only absolute risk factor for heart failure. So this is very important because now outside of cardiac hospital and cardiac admission, in particular diabetic patient, we have like 12% prevalence of high heart failure, and we have hypertension as the absolute risk factor for development of heart failure. So it again regarding epidemiological background, it gives a clue how prevalent heart failure is and what is the main risk factor for heart failure in our population. So what I mentioned is mainly about from epidemiological viewpoint. What is the clinical or outcomes burden of heart failure in our population. This is a relatively small study we conducted in Shab Teaching Hospital, about 200 patients who are admitted with acute decompensating heart failure. These are patients who already diagnosed with chronic heart failure. We excluded any patient admitted for the first time, so acute de novo heart failure were excluded. We only included patients who were already diagnosed with heart failure and now admitted as acute decompensating heart failure. The purpose of this study was to look at the frequency and cause of acute decompensation. So we're just looking at how frequent our heart failure patient readmitted and what is the causes, likely cause of acute decompensation. And just as a background, from this 200 patients, 88% of patients were HFrEF, while 5 to 6% were preserved and mid-range. And this is always what we face in the hospital-based data. We mostly face with HFrEF patient, where about 88% were HFrEF. And this is quite different, I can say, from what we can see in other studies or registries. And also it's different from the data we have still unpublished, but where we have in other setting, I mean in out of hospital setting, where we have like 50% HFrEF or 50% HFpEF, and this is quite consistent with international literature. But anyway, when we study this patient as the hospital admission, we face like this biased data. Anyway, 88% were HFrEF, and the underlying cause of heart failure mainly was dilated cardiomyopathy, ischemic cardiomyopathy, and hypertensive heart disease, and valvular heart disease. And again, this is consistent with the data we have from Sudan, different setting, and also is not far from the recent data we have in Africa. There was one study conducted in Cape Town where they have the same categories like dilated cardiomyopathy, ischemic, and hypertensive and valvular heart disease. So it looks the tetrad of dilated cardiomyopathy, ischemic cardiomyopathy, hypertensive heart failure, and valvular heart disease constitutes the bulk or the make up the whole or almost the whole picture of heart failure in our population. But look at this. This is the time to readmission. And you can see here like 1/4 of patients were readmitted during the first 30 days, and another 1/4 admitted during the first 6 months, to 3 months, and half of patients admitted within 3 to 6 months. So this again is consistent with what we see in international literature, that is 25% of patients admitted were during the first 30 days. But this is one of the most important slides, I would believe. And this is one of the purpose of the study. Look at here, 51% of patients admitted 4th time or more, and 30% were admitted for the 3rd time in the last 6 months. So only 2% it was there the first readmission in the last 6 months. So it looks and clearly that the frequency of readmission is quite high. And we were able to identify the causes of acute decompensation is in 90% of patients. So in 90%, we identified what is the cause of decompensation. And it is not unsurprised that is 1/3 were decompensated and readmitted due to non-compliance, 14% due to worsening renal function, for 11 to ACS and other causes of acute decompensation. So what we could conclude from this study, we concluded that it's very scary to say that 4 out of 5 heart failure patients readmitted 3 or more times during the last 6 months. So out of 5 patients, you will find 4 of them readmitted 3 times or more just during 6 months. And can you appreciate what is the burden of this readmission in the patient, in the families, in the caregiver, in the hospital, and the health system and economy as whole? So this is very heavy burden, and you couldn't see this in any type of disease, I could believe. And again, what we conclude, you conclude that is 30% were decompensated or readmitted due to non-compliance, and 20% were decompensated due to worsening renal function or uncontrolled blood pressure. I personally would believe that is this 50% of decompensation are potentially preventable. Yes, that is, you have 1/3 who decompensate due to non-compliance, which is potentially and absolutely preventable. You have 14% readmitted due to worse renal function, which is again, I believe, can most of it prevented by the way we tackle the heart failure medication and volume status. And another 4 or 5% were readmitted due to uncontrolled blood pressure, which is again, I believe, is potentially preventable. So this high burden of readmission, 4 out of 5 patients readmitted 3 or more times, 50% of this decompensation are potentially preventable. So this high burden, but again, we have good opportunity. That is, we have a good place to work hard in this area where we can prevent and mitigate this is high readmission and decompensation rate. Another study we conducted and published it, we look at the incidence of new onset heart failure in patients admitted with the first anterior ST elevation myocardial infarction Shab Hospital. And this is conducted between August 2017 and February 2018. It's conducted by Mona Mustafa and myself. We basically look at patients who admitted with the first anterior ST elevation MI. We excluded any patient with previous MI. We excluded any patient with previous revasc. We excluded any patient with non-valvular heart disease or congenital heart disease or arrhythmias. So only those who, for the first time, admitted with anterior STEMI, and of course, we exclude other STEMI. So only anterior STEMI, the first anterior STEMI were included in this study. So we collected like 200 anterior ST elevation MI, and we follow them for 6 months after discharge. And after exclusion of patients who died during initial hospitalization, we came up with 42.5%, that's 85 patients develop heart failure during 6 months after discharge, while 45% don't develop heart failure during 6 months. So those who admitted to the anterior ST elevation MI during 6 months, half of them develop heart failure. And that is, again, is very scary, to be honest. Obviously, the characteristic of patient with heart failure is quite different from those who don't develop heart failure. Those who develop heart failure were older, significantly, with p-value 0.09, were more to be female, more to be diabetic, more to be hypertensive, more to be dyslipidemic, more to have family history of coronary disease, more to have history of renal impairment, more to have peripheral artery disease, and more to have ischemic heart disease, but not an MI. So all this medical history was significantly more prevalent in those who develop heart failure compared with those who not develop heart failure, although smoking was not significant as difference between them. There were no difference in regard to reperfusion or the type of reperfusion, blah, blah. The only difference is the PCI to LAD. Those who underwent PCI to LAD, remember, all these patients are anterior STEMI, so all the culprit artery is the LAD. So all those who had PCI to LAD were less likely to develop heart failure. So again, it tells you how prevalent or how common to have heart failure in those patients who develop anterior STEMI, and we know now reverse the LAD is definitely can mitigate this risk factor. The timing is quite in line with what you could find everywhere. 1/3 develop heart failure during the 30 days following discharge, and this is also, I mean, 40% were develop heart failure during the first 30 days, and 40% develop heart failure within in the period between 3 and 6 months. So up to 6 months, we have around 50% of patients who develop heart failure in this type of patient. And you look at this is I love it very much. It's very wonderful. Those in blue are those who have outcome of the study, which is all-cause mortality and readmission. In blue is the patient who develop heart failure, anterior ST elevation, who develop heart failure during 6 months after start. And in red is those who don't have heart failure. All-cause mortality, you don't say red. Yeah, this is true. If you don't develop heart failure, the mortality is 0% during 6 months. So all patients who die during 6 months are those who develop heart failure. Again, it's for readmission. 44% of patients readmitted during the 6 months, 44% of those who develop heart failure, while no any patient in whom there is no heart failure post anterior ST elevation MI had been readmitted during 6 months. So that is to say, if anterior ST elevation MI don't develop heart failure during 6 months, they don't die, they don't readmit to the hospital. And this is quite impressive. And it tells you if we do hard work in order to prevent development of heart failure in this STEMI patient, this is going to be translated into reduction of mortality and reduction of readmission. So what I believe the way is forward. I believe in this. I believe we really need to think positively. If we think positively, then we will improve, or we're going to impact our feeling. Our feeling is going to influence our action, and our action is going to shape our thought. So we need to think positively even in many ways. And what the definition of positive thinking? Positive thinking is a mental and emotional attitude. So it is an attitude. That is mean we can learn this. We can learn how to think positively. We can learn how to make our mental, our brain, our emotion behave and think positively. And this positive thinking is going to open opportunity to achieve greater result in our career and life. If we really need, or we really wanted to improve our heart failure outcomes and have more data about our patient and our heart failure situation in Sudan, then first step, I believe we need to think positive, and we need to shift our thinking into a positive thinking. And also, I believe the second thing we need is to do this. This is what is very famous, is in our decision matrix, is very known, that David is in Howard. This is a non-American. He's 34th president of US. He's one of the very famous army leader in US. And actually, he's the one who made the strategy to invade Europe during the Second World War. Is in our decision matrix entitled, that is, you look, if you want to do anything, you need to look, is it important or not? Is it urgent or not? So if you have something that is important and urgent, then you should do it now. And now it means you need to do it during the same day. If you have something that is important but it's not urgent, then you need to decide to do it, to schedule to do it other time. You don't need to do it now, but you need to make a decision when you are going to make it according to your timing. If you have something not important but not urgent, you should delegate this to someone else to do this. And if you have something that is not important and not urgent, then you need to delete it. You need to eliminate it. This very simple decision matrix, it works in even higher level, because it is known that we are wasting a lot of effort and we are missing a lot of opportunities because we are not managing our time well. So if, again, first step, we think positively. Second step, we make our decision according to how important and how urgent the matter is. I believe we would achieve more and more. And The way forward, this video I am not going to play because of the time, but it's mainly speaking about teamwork. So in my opinion, I believe if you are going to go forward, I believe you need these three things. We need to think positively. We need to prioritize and better management of our time and opportunities, and we need to have teamwork. And thank you for attention. And hope I didn't exceed the time so much. Thank you.
Awesome. Okay, thanks, Yagoub, for this nice and elegant presentation. And thank you for sharing this valuable information. And looking forward to see you back in Sudan soon. It's my pleasure. Yagoub, if you don't mind, you could stay with us because the organizer here, they feeling the question will be at the end of the presentation. Sorry.
I stopped here.
Okay, and it's a pleasure to introduce Nisrein. Nisrein Elgasim is one of our ambitious young cardiologists, other cardiologists at Elgasim Hospital. She's going to share with us the experience of heart failure unit and heart failure management in Sudan, East Hospital, mainly on Elgasim. Come on, Nisrein, the floor is yours. Thank you.
السلام عليكم. كل عام وانتم بخير. والحمد لله we are back again after this pandemic which troubled us a lot. Alhamdulillah, gradually we are back to our activities, hopefully to resume all our activities back again as before. Thank you, the audience and the organizers for introducing me for this presentation. I would like really to show our experience here in Sudan for experiencing the first idea of multidisciplinary team that is in the multidisciplinary heart failure clinic, which was established at Elgasim Hospital. So, as an introduction, you all know that heart failure is a common cardiovascular disease with high morbidity and mortality. At present, about 26 million people worldwide are suffering from heart failure. Slide. I'll help with the slide. Okay. That's okay. This one. Okay. And as you all know, despite the advances in medical and device therapy in heart failure with reduced ejection fraction, still HFrEF carries a mortality of 50% at 5 years and a high rate of hospitalization. That is, at 6 months, it is around 46%, and at 1 month, it's around 25%. So as you all know, a quick review about the essential management in heart failure. As you all know, that with successive admissions, the mortality increases. So and heart failure, and especially HFrEF, carries increased rate of hospitalization and readmission. And the more the rate of readmission, the more is the mortality. And mainly the first period after discharge, the first month after discharge, this carries the worst and the highest rate of mortality. As you all know, the medications that are approved by the guideline-directed medical therapy, the ACE inhibitors and the beta blockers, the ARBs, the mineraloreceptor antagonist receptors, the RNAs, and the ivabradine for controlling the heart rate. All these medications are the guideline-directed medical therapy and proven to improve mortality and improve the prognosis in heart failure. And the more they combine the medication, the more the outcome is preferable, and the more the mortality is reduced, and the more the rate of hospitalization is reduced. The more, as you can see, the more they combined the RNAs with the beta blockers and MRAs, it carries the best survival. And so the better the initiation of therapy and complete therapy at discharge, this carries the best survival rate in heart failure medication. And as you all know, once the patient is admitted with heart failure, he is in the acute phase and the initial phase where the phase of offloading the patient and improving his economic status, and then starts the thinking of preparing the patient for the chronic state, where the initiation of triple therapy with AC inhibitors and ARBs if AC inhibitors are not tolerated, with a combination of beta blockers and MRIs according to the guidelines as depicted in the guidelines. This is the best way to prepare the patient for the best prognosis, and then his symptoms are reassessed again. If the patient NIHA classification has improved, then we continue in our same plan. If the patient NIHA classification did not improve, then we go for the RNAs, and now the new guidelines dictate that we can start with the RNAs immediately. And there is an issue with the heart rate, since we know that the more the heart rate after discharge, if it's more than 70%, we need to bring it down. And here we use, if it's not controlled by the beta blockers, then we go with the ivabradine. And if all this didn't work, then we may need to shift for other modalities of treatment. Or if the patient still was in AF, then we cannot go for ivabradine because it is used much for those with sinus rhythm. So rather we can go for other modalities of treatment, and we keep assessing the patient. Again, all you know, this happens during admission. Meanwhile, we carry with us the diuretics for offloading the patient, and then we put in our mind planning the patient if he's improving for continuation of treatment, or the patient is not improving, then we think of advanced therapy, either in the form of device therapy or planning for end of care or end of life for the patient. So, as we told before, as we mentioned in the previous slide, this is the patient goes from the state of acute heart failure and in the hospitalization state where the medication are initiated for the acute phase, and then the patient goes for the chronic heart failure status. And here, the first months after discharge, or even much better in the pre-discharge period, this is the best way to start our medications, the guideline-directed medical therapy in a combined fashion, so as this is the most vulnerable phase, and then this is the most targeted phase to improve the patient mortality and morbidity. So from the previous conclusion, what we come to is that the mortality and readmissions are high after discharge for heart failure, and better adherence to guidelines recommended therapies improves the outcome, and hospitalization is the key moment to optimize treatment. So effective therapies are available, and then they need to be used. So how to be used in this context, in our very busy clinics, very busy outpatient clinics, how can we manage to achieve this better combination for the patient? So we need to have a pre-discharge and long-term plan of management. That is to develop a careful plan that provides who will see the patient and when, a schedule for up-titration and monitoring of drug therapy, and a need and timing for review for device therapy. So this can be achieved by enrolling the patient in a disease management program. And that is, we can see the patient, or the patient can be seen by the general practitioner within 1 week of discharge, or to be seen by the hospital cardiology team within 2 weeks of discharge. This is the best way to achieve this, because as we said, the first period after discharge is the most vulnerable period for readmission and for mortality. So, heart failure with reduced ejection fraction. All recent studies show that HFrEF treatment is suboptimal. Mainly, all the patients are moving around with suboptimal medications. And per clinical guidelines, these agents should be initiated and titrated every 2 weeks to target or maximum tolerated dose. And definitely this is difficult to achieve in our busy outpatient clinics, in our busy wards. So there is a gap between clinical trials and the real world setting. So the message that the mission of providing the patients with the optimal treatment is a mission that deserves much effort and attention paying. It is highly recommended in the ESC and Heart Failure Society of America guidelines to have a special care for heart failure patients, and such as and this can be manifested in heart failure disease management programs. So now disease management programs for heart failure have three overlapping categories. It is either the heart failure clinic, either in the inpatient setting or the outpatient setting at the level of the district or in the community, or home care, or telemonitoring over the phone. These are the components of disease management program. So about the heart failure care team, who are the providers of the multidisciplinary heart failure care team? We have the primary care providers. They can be general practitioners either at the hospital or at the community level. We have the heart failure cardiologist, the heart failure nurses, the clinical pharmacists, specialized cardiac providers like the electrophysiologists and cardiac surgeons for advanced therapy, dietitians, psychologists, and social workers, and also the cardiac rehabilitation team. All this can be carried in both the inpatient and the outpatient settings. So this is the diagram providing that both settings can be provided either inpatient or outpatient at the level of the community with the district doctor or the district nurse or any specialized team outside in the community. We have the heart failure cardiologist and heart failure nurse in the hospital. The same thing, we can have a heart failure cardiologist and heart failure nurse at the level of the community. We can have primary care providers, subspecialties, mental health providers at the level of the community. The same way we can have them consulting providers at the hospital. We have clinical pharmacists at the hospital. At the same time, they can be provided at the community level, social workers at the hospital, home, healthcare, social workers at the community level with dietitians, physical therapists, exercise, physiologists, and dietitians and physical therapists at the hospital. So with closalization, it can be provided at both levels. So heart failure clinics, do they work? In a systematic review of 29 trials for multidisciplinary strategies for management of heart failure, it showed that heart failure clinics showed a significant decrease in mortality, heart failure hospitalization, and all-cause hospitalization. So what is the aim of the heart failure clinic? We have two aims, either to improve the mortality by improving the prognosis. If this is not possible, we can improve the functional capacity of the patient, and the patient can be turned from a morbid disabled person to a healthy, productive one, full of life and prospects. So what are the domains of the heart failure clinic? First, we have the disease management program, and this is provided by the doctor and the nurses, detailing and providing the guideline-directed medical therapy. And this constitutes also the functional assessment of the patient. This can be achieved by the NIHA classification, by the 6-minute walk test, and by the cardiopulmonary exercise test. And definitely at simple clinics, you can just go with the NIHA classification and or the 6-minute walk test. You need the quality of life of the patient, and this can be achieved through several questionnaires. There are known international questionnaires for assessing the quality of life of the patient. Minnesota Living with Heart Failure questionnaire, the Kansas City questionnaire, lots of questionnaires for details of the heart failure of the patient, quality of life, showing his quality of life, how he can achieve his daily activity, his job, his satisfaction. We can follow them for the patient improvement and patient satisfaction. And then there is the domain of medical therapy and drug evaluation. And this can be both done by the doctor, the cardiologist, and even by the nurse. We have the nutritional assessment, and this will be covered by the dietitians, can go detailed among them. The cardiac rehabilitation team, the psychology, and we should have a very proper plan of follow-up for the patient and follow-up even of the practice of the clinic. The patient should be followed by a proper plan to see the progression and improvement, and even the team workup should be followed up properly for organization and homogeneously between the different parts of the team. Communication is a quite important part we need to have a very proper way of communication and communicating the information properly to the patient, and even communication properly between the team, so as informations are not conducted in a way that is not consistent. And so there should be a very tight and well-evaluated level of communication between the providers and the patient, and between the providers themselves. Also, there should be a comprehensive education and promotion of self-care. This could be provided by education means and tools for the patient, and helped by the nurses specialized in heart failure. And advanced planning, this, if the patient is improving, it's okay. If it's not improving, then we can go for advanced planning like device therapy. We can refer the patient for electrophysiologists, as you all know, for TRTs or ICDs, or even planning end of life if the patient is not showing any improvement. Quality assessment of all these programs should be clearly achieved by following all these domains of the clinic one by one, and showing how it's quality controlled. So these are the domains of heart failure clinic that should be applied when you are thinking of establishing a heart failure clinic. So what is our Sudanese experience with these international guidelines? At Elgasim Hospital Cardiothoracic and Renal Transplantation Center, we had established the multidisciplinary heart failure clinic in June 2018. And the role of our team, we tried as much as we can to achieve these domains that we discussed here in this clinic. These domains are according to the Heart Failure Society of America, provided by these domains of the clinic, and we try to optimize and to adopt these domains as much as we can in our clinic. So we had our team. The team constitutes with our nurse, that she's the first one that comes the patient. When the patient comes into the clinic, the first he meets the nurse that is trained in the heart failure program. She introduces the patient to the clinic and different specialties, show that this is a multidisciplinary clinic, and he will move among all other specialties. We will come on with them. And she takes the initial assessment of the patient. She takes the data, the vitals, and the weight of the patient. She gives education of the patient. And here we designed a patient information booklet. It was designed according to the American Heart Association guidelines. It's in Arabic. It's simple for the patient information to educate the patient about his illness, about the causes and the precipitating factors. And it was linked with weight tables for weight measurement to keep the patient close to the leaflet. And so the patient goes with this education, and it handles the patient information leaflet to the patient. We have then the patient then moves on to the doctor, who conducts the full assessment of the patient condition, addressing the euvolemic status, takes the history, the general examination, revising all the investigations, addressing any acute condition, warranting further plans. So as the patient can present with chest pain, he may need referral back to the clinic, or he may present with acute decompensated failure, he may need admission, or the patient can present with any state of decompensation, like decompensated arrhythmias, atrial fibrillation. So he takes the suitability of the patient. If he's in an acute condition that needs further workup, or if the patient is quite stable, then the patient is suitable for the up titration process. Then the patient moves on forward for the clinical pharmacist. They sit together with the doctor and liaising all the medications together and all the plan. And the clinical pharmacist's role is to optimize the guideline-directed medical therapy and review all the patient medications for other comorbidities. Usually they are hypertensive, diabetic, in atrial fibrillation with warfarin. Most of them have ischemic heart disease. They have multiple medications. So this is the role of the clinical pharmacist, to define the medications and to take to optimize the doses and minimize the side effects as much as they can, and to promote the patient adherence. Usually we experience that these patients come with a hell of medications from different companies, and the medications usually are so much look alike from different companies that the patient can mix between them. So usually the clinical pharmacist sits down and put all this into order and help the patient go and adhere to his medications. Now we have the dietitians, and really the magic of the multidisciplinary team comes here from the other disciplines. We are doctors and nurses and clinical pharmacists, go with the usual role of the doctoring of the patient, which is familiar with all of them. But usually the magic of the clinic that we experience was with the other disciplines, like the dietitians. One of the examples. they optimize the nutritional status of the patient according to the patient is, if the patient is thin, if he's fat, if he has any other comorbidities, hypertensive, diabetic, taking warfarin. They optimize, tailor this with the required and needed dietary plan. And with the heart failure consideration, they optimize the salt intake and the water intake according to the evolume status of the patient. They know that the patient intake of salt should be within 1,500 to 2,500 milliequivalent. So they do all this and tell the patient how to use them with the ordinary salt at home. Usually have magic presentations for those in details according to their discipline, but definitely the time is not enough to show all these disciplines in details. Also, they unify an optimum nutritional plan tailored to the patient's social circumstances. If the patient is poor, for example, is poor and cannot take enough meat and so forth, they can tailor it to what is suitable from other food components. We have also the psychologists. They are handling the psychological burden of the disability of heart failure on the patient and caregivers. Most of the patient and caregivers are depressed and have anxiety about the situation and the prognosis. So they tackle this part of the patient and help both the patient and the caregivers of handling their disease. And they try to bring up them to the desired level of psychological stability, well-being, and fruitfulness. Definitely, they deal with all other harmful situations and habits like smoking, alcohol addiction, tobacco, whatsoever. And they deal with all other stresses the patient faces. Definitely, the patient have other stresses in their life, loss of work because of heart failure, cannot have enough income for the family. Other stresses in life, they can tailor it. If the patients and caregivers are quite anxious about the patient morbidities, they can tackle all these stresses together and bring up the best possible achieved well-being of the patient. So the dietitians, the cardiac rehab, and the psychologists really carry the magic of the multidisciplinary team. The cardiac rehabilitation team, they assess the functional status of the patient. Usually they do the 6-minute quad test in front of the clinic. They draw the line for the 6-minute quad test and they assess the functional capacity through it. And they take our notes about the NIHA of the patient. They address the patient risk factors. Also, they assess the physiotherapy assessment and they exclude any neurological or orthopedic problems because they tackle this all together. A lot of patients are obese with osteoarthritis, other neurological morbidities, or any orthopedic problems. They tackle all this together and they take them for the rehabilitation process, which is held at the Cardiac Rehabilitation Center at Elgasim Hospital. So the dietitian, the cardiac rehab, and the psychologist really bring the best of the well-being of the patient, in addition to our doctoring of the patient with the pharmacists and the doctors and the nurse. So additionally, we have other organizing tools to help with the smooth follow-up of the clinic. As we said, this booklet, which is the patient information held in by the nurse and educate the patient. And we designed a special file for the clinic, which is different from the hospital file. And it is specially designed for the disciplines for each of them to have their notes and to have their follow-up plan and to have their assessment plan. It is detailed and it is designed according to what suits best the other disciplines. So all of them, the doctor, the nurse, me, the cardiologist, and the cardiac rehabilitation team and the dietitian and the psychologist, they all have here their notes and progress of the patient. And also we have a referral form. This is distributed among other units to help with proper patient selection and criteria for referral. And also we handle in this referral form the investigations that we need. It is the investigations are needed by the doctor, by the dietitians, so as they can tailor their medications and their dietary plan. So this is the patient journey to and from the heart failure clinic. We admit all patients with reduced ejection fraction, HFrEF as the definition, less than 40. And then the patient is, the referral usually should be made by cardiologists after excluding all reversible causes like ischemic causes needing any sort of revascularization, any valvular problem. When the patient is just a heart failure patient and needs for up titration, he should be referred to the clinic. The patient goes and the clinic is designed only on 2 days on 2 days of the week. It's just only held on Sunday and Wednesday, and it starts later at the day because when we come to establish the clinic, this tells that limited resources we can achieve a lot. When we thought of establishing this clinic, All what we did is that we gathered the head teams of the departments, the head teams of the nutritional department, of the psychology department, the cardiac rehabilitation department, and every hospital is full of nurses and full of doctors and clinical pharmacists. So we needed from any department one representation. We sat together, we did our meeting, and then we decided to sit together in one room so that we can achieve our goal and help this patient rather than moving along the departments. So we sat together, we went to the outpatient department, and there we found the most wider room that can accommodate us all. And this room should start later after it finishes the previous activity. We usually sat in the cardiac surgery room. After they finish at 12 p.m., then we start our clinic. So it was just a matter of dedication and need of helping the patient, all what we needed. The team was highly encouraged by the outcome and the teamwork and the soul of the team, and loving of what we are providing for our patient, and the patient satisfaction was the main drive for us to carry our clinic. So we have constraints, we have time constraints, we have place constraints, but still, in spite of this, we can sit together and we can manage ourselves in this area that can accommodate us all. We provide a special area for the doctor and the psychologist where they need the most privacy for examining the patient and taking the detailed psychological patient, and then the rest of the team sit in the bigger room, and all together we sit together and discuss the patient together. And because these days are the only days that are short enough during the day, so just only 2 days of the clinic was enough. That is Wednesday and Sunday. So it was a matter of organization, will to achieve a target goal. We didn't, and even this team doesn't have more incentives or any more fees paid for this extra activity. It was just the will and the dedication that held all this together. And even the time, because it starts 12 p.m., sometimes we sit late in the day up to 6 p.m. Those who have transportation with the hospital leave earlier. Those who have cars sit. It was just, as I said, the matter of will, desire, and the teamwork that helped us to carry this process. The patient goes through this titration process every 2 weeks, according to the patient's suitability, or every month, according to the patient's situation. Here the titration process goes. And after the patient reaches the maximum tolerated dose or the guideline directed maximum dose or the maximum tolerated dose, then the patient is suitable for discharge from the clinic to go back to his unit again. At this time, there is a clear report about the patient, and new echo is done about him to see if there is any improvement in his ejection fraction, any improvement in functional capacity. If the patient is need for referral for the device consultant, we had the device consultant was cooperative with us for any need for CRTD or ICDs. This is the process of the patient and along our clinic. So the referral criteria, any patient with reduced ejection fraction of around 40, chronically on low dose of beta blockers, most of them are scattered among the hospitals with low dose of beta blockers and AC inhibitors. Any ischemic cardiomyopathy after coronary angiography is done, and a clear decision is made if the patient needs revascularization or not. And actually, all MI patients with low ejection fraction will benefit from quick up titration, whether thrombolized, PCI'd, or are planned for CABG. Definitely, any reduced ejection fraction, idiopathic cardiomyopathy, peripartum cardiomyopathy, hypertensive, postviral, alcoholic, valvular heart failure deemed non-operative will be referred for us for optimization, and any post-operative valvular heart failure for optimization. Those are the patients who are usually referred to the clinic. The investigations required for referral: blood urea and serum creatinine for the process of up titration, sodium electrolytes, CBCs, fasting lipid profile, glucose and uric acid, because we optimize the patient condition, we control the diabetes, we control the hypertension, we maximize the warfarin, and all the medications are tailored together for the best of the patients with the help of the clinical pharmacist and the dietitians. So the patient, among these 3 years, we had more actually than 225 patients. The mean age was around 58 years, and most of them were males, and most of them were married, around 80%. And most of them were from Khartoum area. It was extremely difficult to follow up patients outside Khartoum, so it was mainly for those residing at Khartoum. And the mean heart failure duration was around 5 years. And the main etiologies, DSM was around 52%, ischemic around 30%, hypertensive 9%, and other like peripartum around 8%. And the outcome of intervention, of up titration, At presentation, those only 5% was initially at the guideline-directed medical therapy. At the end of the titration process, 70% from them was suitable and can achieve the guideline-directed medical therapy. The functional capacity, 98% of them showed improved in functional capacity, and this is the main target of the clinic. Because only the ejection fraction is not achieved a lot, and this is what documented in the guidelines. Only the improvement was around from 30 to 40%, but this big improvement in the functional capacity was what is needed for controlling the patient's symptoms, for the patient coming back to life, for the patient coming back to work, to alleviate the stress from the caregivers. So this magic of 98% was the main goal, and it helped a lot from turning the patient from an ill, comorbid, frequently hospital admitted patient to a patient full of life, back to his work and back to his family. Now, this is the pioneers initially of the clinic. This is our first nurse in our heart failure clinic. And here are one of the team of the dietitians and the psychologists. Usually we have a turnover with the dietitians and the psychologists and other disciplines. This is one of the cardiac rehabilitation team. This is the doctor of the quality control. And here is our clinical pharmacist and one of the clinical pharmacists conducting his research in heart failure clinics in our clinic. And this is the doctor of the clinic. And here, the team, all of us together, when we initiated the clinic, but now we have a turnover of all these disciplines together moving around the clinic. So, what are our plans for the near future and the far future? For the near future, we need a telemetry follow-up for the heart failure clinic through telephone so that we can really follow up these patients properly. And really, the telephone was showed that it improves a lot in the guidelines. It showed a lot in the evidence-based medicine that it helps a lot in improving the prognosis and reducing the rate of hospitalization. This could be linked with a hotline, and for each for all the disciplines, more for that one for the psychologist, one for the dietitians, and so forth. Because some patients need more psychological care than others. Some of them need more dietitian, nutritional care than others, and some need a follow-up for their euvolemic status more than others. So this will help a lot in reducing the burden and improving the outcome, both from mortality and morbidity. And definitely we need a specialized heart failure team for inpatients, because the sooner, the earlier we start our process, the up titration, the better is the outcome, as we showed in our previous slides. And we need support groups for these patients and education groups so that these patients together can stay together, and we can alleviate together their problems and help with improving their situation. And for the far future plan, we need heart failure care should be at the community level with close liaison with the primary health care physician and the district nurse. Okay, I finished almost. And we need a full heart failure national program, including electrophysiologists and device consultants for ICDs, CRTs, and pacemaker insertions. And definitely we need a heart transplantation program for non-responders with special eligible criteria. And definitely we need a hospice for end-of-life care. Thank you very much.
Thank you for Dr. Nisrein for her comprehensive talk about what's happening in Elgasim Hospital. It's my pleasure to introduce Dr. Sara Mohammed Musa. She is an adult cardiology fellow to talk about what's new in the management of heart failure of this year.
Good evening, everybody. I hope to enjoy this presentation. Thank you, Dr. Yagoub and Dr. Nisrein, for the previous presentations. كيف أمشي؟ So I'm going to talk about what is new in the management of heart failure 2021. First, I will give you brief short definition and the proposal universal definition describe heart failure as a clinical syndrome with the symptom or signs caused by structure or functional cardiac abnormality and corroborated by elevated natriuretic peptides levels or objective evidence of pulmonary or systemic congestion. And the heart failure stages have been revised to emphasize the symptomatic nature of the heart failure as a clinical syndrome. At the risk of heart failure, this is stage A, pre-heart failure, new. This is stage B, symptomatic heart failure. This is stage C, and this is the area of the treatment. And advanced heart failure, this is stage B. And the classification of heart failure according to the ejection fraction now include heart failure with reduced ejection fraction, less than 40%, heart failure with mid-range ejection fraction, this is between 41 and 49, heart failure with preserved ejection fraction, and this is symptomatic heart failure with ejection fraction more than 50%. Heart failure with improved ejection fraction, this is symptomatic heart failure with a baseline ejection fraction less than 40% with treatment increase more than 10 point increase from the baseline ejection fraction, and the second measurement found to be more than 40%. And this is the definitions, stages, and classification by ejection fraction. So I'm going to talk about how to initiate, how to add, how to switch on. According to the new evidence baseline guideline directed medical therapy for HIF, heart failure with reduced ejection fraction only. Established therapy for chronic heart failure with reduced ejection fraction include angiotensin and nerlibresine inhibitor, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, beta blockers, loop diuretics, and aldosterone antagonist, hydrolyzine and isosorbate dinitrite, and ivabradine, an IF channel blocker, highly selective for those on sinusoidal node pacemaker current. With the exception of loop diuretics, all of these therapies have been shown in a large randomized controlled trial to improve symptoms, reduce hospitalization, and or prolong survival. Regarding digoxin as a treatment of heart failure with reduced ejection fraction lacks any new data. Most of it is used in modern HFrEF management, focus on its role, rate control of atrial fibrillation, or in those who have low blood pressure and recurrent hospitalization. This image shows the 10 pivotal issues that have been discussed in the last January meeting and the guideline directed pathway therapy. First, how to implement guideline directed therapy, how to initiate, add, or switch. Second, how to titrate this medication, and how to address challenges, how to refer, when to refer patient to the specialized heart failure clinic, and the care coordination, and how to help patient to adhere with his medication, and specific patient cohort evidence-based recommendation and assessment of risk of a special cohort, African American or older adults. Those are special people. We give special medication. And to discuss the medication cost and with the patient, and to address this, because most of the new medication are very costly. Increased complexity, 12 pathophysiological target in heart failure with reduced ejection fraction. We know all this medication first medication and guideline based beta blocker are bisoprolol, carvedilol, and metoprolol. Starting dose 1.5, 3, 125, 12.5, 25 milligram respectively. And the target dose for each of these medication, 10 milligram once daily, 25 milligram twice daily. If the patient less than 85 kg, and 50 milligram twice daily if the patient weight more than 85. Metoprolol, succinate, 200 milligram daily. Sacubitril valsartan, 25 starting dose, 25, 26 milligram twice daily. It is 50 milligram twice daily. This is starting dose, and the target dose is 200 milligram twice daily. ACE inhibitor, captopril, enalapril, lisinopril, and ramipril. For captopril, 6.25 starting dose, 3 times daily, and 50 milligram 3 times daily. This is maximum dose. Enalapril, starting with 2.5 milligram twice daily, targeting 10 to 20 milligram twice daily. Lisinopril, that commonly used, 2.5 to 5 milligram twice daily, once per day, and maximum dose 20 to 40 milligram per day. Ramipril, starting with 1.25, and the maximum dose 10 milligram daily. ARB, candesartan, losartan, valsartan, candesartan 4 to 8 milligram daily, maximum dose 32. Losartan 25 to 50 milligram once per day, maximum dose 150, and valsartan 40, and the maximum 160. Aldosterone antagonist, iblirinon 25 milligram, and maximum dose 50 milligram. Spironolactone 12.5 starting dose, and maximum dose 25 to 50 milligram. As GLT2 inhibitor, dapagliflozin and empagliflozin, 10 milligram, and continue with the 10 milligram. Vasodilator, hydralazine, 25 milligram, 3 times daily, maximum 75 milligram, 3 times daily. Isosorbate dinitride, 20 milligram, 3 times a day, maximum dose 40 milligram, 3 times a day, either at the fixed dose combination. If you use fixed dose combination, isosorbate dinitride with hydralazine, 20 milligram, 37.5 milligram, as a 1 tabs 3 times daily, or 2 tabs 3 times daily, maximum dose. Ivabradine, start with 2.5 to 5 milligram twice daily, titrate up to heart rate 50 to 60, maximum dose 7.5 twice daily. How to initiate and when to initiate? If the patient is congested, I'm going to start with beta blocker or ARNI or ACE inhibitor. And guideline, stage C treatment, start with ARNI, or in the last guideline said start with ARNI if in de novo patient, that patient not receive ACE inhibitor or ARB before. In the paradigm heart failure trial, this is compared ARNI with enalapril And this is before the patient already taken AC inhibitor. We compared the endpoint, primary endpoint result. They found that the number needed to treat, the number of patients needed to be treated to reach primary endpoint was 21. And the cardiovascular death reduction was 20%. Then when the Pioneer trial, this is in de novo patient, they found when start ARNI in naive patient, they found that this is improved the outcome and this is improved outcome and the cardiovascular risk and the symptom of the patient. Yes. هشوف And in the last guideline, they said that if you start with ARNI, will be the best. And if not, you can start with AAC inhibitor or ARB. ARNI is preferred. And then you can add beta blocker after the patient is dry. This is well tolerated when the patient is dry, and the ACA, ARB, ARNI well tolerated when the patient is wet. This is in combined with diuretic agent as needed. It is better with the less amount of diuretics and less dose of diuretics before to start with ARNI because of hypotension, and this is a major side effect of the ARNI. Then, as needed, you can add aldosterone. Before to add aldosterone, you have to check the GFR. The patient, also for ARNI, you have to check the GFR should be more than 30 ml per minute. And creatinine for the aldosterone for male should be less than 2.5 milligram, and for female, less than 2 milligram. And the potassium should be less than 5 milligram. The patient symptomatic stage C, NIHA class 2 to 4. For patient median eGFR criteria, GFR more than 30, you can add dapagliflozin, and GFR more than 20, you can add empagliflozin. And this is new in the guideline. For the patient with persistent volume overload, you can titrate the diuretics as needed. And if the patient is still overloaded, you can shift from loop diuretics to the other type of diuretics. For persistently symptomatic patient, still the patient use the 4 medication and is still symptomatic, or the patient is a Black American, you can add hydralazine plus isosorbate dinitrate. So even the other patient who is still symptomatic or have recurrent hospitalization, you can add hydralazine plus isosorbate dinitrate. Put in your mind, the patient, you should titrate it up to the maximum tolerated dose or the targeted guideline dose. The patient reached the guideline dose, that is okay. If the patient cannot tolerate, you have to reach the maximum medication that can be tolerated by the patient. So if the patient reached the maximum heart rate, the maximum beta blocker, the guideline directed, and still his heart rate more than 70, and he is in a sinus rhythm, and still symptomatic, you can add ivabradine as those mentioned before. In ARNI, if the patient is previously on ACE inhibitor, ensure 36-hour, 48-hour washout period because of risk of angioedema. And if the patient is taking ARBs, you can start immediately. About the doses, if the patient is taking equivalent of less than 10 milligram of daily enalapril, you can start with 50 milligram BD. If the patient taking maximum dose of enalapril, you can start with 100 milligram twice daily, not more than this. This is the starting dose. And to titrate all these medication, you have to titrate in 2 weeks to assess the tolerability of the medication, to assess the blood pressure, and to assess the renal function. AC and ARB considered in patient where ARNI administration is not possible, either due to cost, as is in here, or not tolerated because of hypotension. Select initial dose, as mentioned, and consider increasing the dose to maximum tolerated target dose. Monitor blood pressure and renal function. Also, patient with advanced renal disease, you cannot give him ARNI, you can give him AC inhibitor or ARBs. Evidence-based beta blocker initiated with, as mentioned, and titrated as tolerated by the patient and reaching the target guideline medical directed dose. Every 2 weeks, a maximum tolerated target dose should be achieved, and the heart rate, blood pressure, and sign of congestion after initiation should be monitored. The diuretics, and this is for symptomatic to decrease symptom and also to decrease hospitalization because patient presented to hospital because of symptom. Initial dose depend on multiple factors, including renal function and prior exposure to drug diuretic therapy. Titrated dose to relieve congestion. Start. You can start with moderate dose and over days to weeks. In some instances, it may be necessary to reduce the diuretic dose before starting ARNI and AC inhibitor. Monitor blood pressure, electrolytes, and renal function. If reaching high dose of diuretic and still the patient congested, consider changing to different loop diuretics or adding thiazide diuretics taken together with loop diuretics. Monitor blood pressure and electrolyte and renal function. Aldosterone initiated as we mentioned before the dose, consider increase the dose every 2 weeks, putting in your mind GFR, serum potassium, and serum creatinine. Check first, then after 1 week, then after 1 month, then every 3 months. According to the patient clinical scenario, you can monitor the patient. SGLT2 inhibitors, select either dapagliflozin or empagliflozin. Ensure a GFR more than 30 in dapagliflozin and more than 20 in empagliflozin. In hydrolyzing plus isosorbate dinitrite can be initiated if the patient is still symptomatic. Select the initial dose as mentioned before, and either as a single or combined fixed dose. Consider to increase the isosorbate dinitrite every 2 weeks. Ivabradine, reassess a patient. Beta blocker, if the patient cannot tolerate the maximum or a target dose, and the patient is in sinus rhythm, then you can start ivabradine 2.5 milligram twice daily. If the patient is more than 75, 2 milligram twice daily. With food, if less than 75, 5 milligram twice daily. Reassess a heart rate in 2 to 4 weeks. So this is indication for ARNI as HFrEF less than 40, NEHA class 2 to 4, administered in conjunction with the guideline directed other medical therapy, and all this we come through. So There is, the last release is a simultaneous or rapid sequential initiation of medical therapy of heart failure, seeking to avoid case too little, too late. If you didn't start the guideline directed medical therapy in the hospital before discharge, you are not going to start it after that. This is a diagram showing the initial starting dose every 2-4 weeks, titrate an AC inhibitor, beta blocker, MRA, and RNA every 2 to 4 weeks, titration, SGLT2 inhibitor, starting dose with and go with the same dose. You can start all this medication on the same day if the patient condition allow. This is the comprehensive disease-modifying medical therapy from day 1 up to the 42 day, and start and go. Beyond that, maintain further optimization of foundation therapy, consider EB devices therapy on mitral clip if the patient is still symptomatic and there is severe mitral regurg. Consider of art therapy or advanced therapy like ICD and CRT if the patient on the maximum guideline directed therapy and still symptomatic. And the benefit of each treatment demonstrated within 30 days of initiation, cumulative benefit within 30 days, 75% relative risk reduction. And this is the benefit, rapid improvement in health status within 1 to 2 weeks, rapid reduction in heart failure hospitalization, rapid reduction in mortality, and rapid improvement in ejection fraction, and rapid reduction in heart failure hospitalization, and improvement of use and adherence to this medication. When you start all this medication together in the hospital, there is a better adherence to this medication. And this is a study, and this is meta-analysis of the 3 studies, emphasis for eplerenol, paradigm, and dapagliflozin, and showing heart failure with reduced ejection fraction, comparative analysis of 3 studies, showing that if you start all this medication, extend your patient life by 6.3 years, and reducing cardiovascular death and heart failure hospitalization. And this is the relative risk reduction in every medication. In ARNI, 28%, and the 2-year mortality, 25%, beta blocker, 35%, and the 2 years, 16%, 16.4%, aldosterone antagonist, 30% relative risk reduction, and 2 years, 11.5%. SGLT2 inhibitor reduction by 17%, and 2-year mortality, 9.5%. Found the beta blocker having high relative risk, highest relative risk reduction. And the cumulative risk reduction of all these medications together is 72.9%, and absolute risk reduction about 25.5%, and number needed to treat is 4. The benefit approach to heart failure to reduce ejection fraction medication, the benefit of HFrEF medication are additive and incremental, and no substantial overlap has been demonstrated for 4 key evidence for all the 4 medication. And SGLT2 inhibitor improve outcome in heart failure patient with and without type 2 diabetes. And also impressive that they slow down reduction in renal failure, or if the patient is CKD, if you start with SGLT2 inhibitor, there is a slowdown in the eGFR reduction. The optimal approach is to utilize each medication to reduce all-cause mortality in combination, if not contraindicated. A serial or selective approach lead to delay and heart failure hospitalization. Death could have been prevented with earlier use of guideline-directed medical therapy. And these 4 drugs each provide high economic and clinical value. And this is the expert opinion, and this is a Canadian pathway. It is the same. They put the 4 medication together, and they add If the patient is still symptomatic, you can add Fersiquet, is a guanylate cyclase inhibitor, and this is if the patient is still symptomatic. This is a Victoria trial. This is a paper, and this is a recommendation for all medication. As you see, all of them are class 1A. The new is dapagliflozin and empagliflozin is recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. This is the class 1A. To start, sacubitril valsartan with SGLT2 inhibitor also, it is possible, and this will be additive and lead to more slowdown in the renal impairment. Heart failure and comorbidities. What is new in atrial fibrillation? The class 1A. The class 1 is a direct oral anticoagulant as recommended and preferred to vitamin K in patients with heart failure and atrial fibrillation. 2016 was 2A. And the medication for the rate control of atrial fibrillation, beta blocker is the first. Doubtful impact on the mortality, should be administered for heart failure prognosis. Calcium channel blocker indicated for HFrEF, contraindicated for HFrEF. Amiodarone, if the patient as additive to digoxin and beta blocker. Digoxin is adjunctive to the beta blocker when it is inefficient or contraindicated. And this is for anemia and iron deficiency in patients with heart failure. It is recommended for all patients to be screened for anemia with full iron study and ferritin and transferrin saturation. And if the patient have transferrin saturation less than 20%, and serum ferritin less than 100 or between 100 and 200, you can supplement with ferric carboxymaltose, should be considered. For patients with heart failure and cancer, it is recommended to increase the patient with heart failure and cancer, cardiotoxicity is increased, so the patient can be managed with cardiologist experience in cardio-oncology. AC inhibitor and beta blocker is preferred and should be used in cancer patients with reduced systolic LV function. This is, what is new in HFpEF? In patients with heart failure and preserved ejection fraction, there is no clear guideline for treatment, but in those people and chronotropic incompetence, withdrawal of beta blocker resulted in substantial short-term improvement in peak oxygen uptake in the preserved heart trial. And this is showed beta blocker kept and beta blocker withdrawn. This is the effect on the peak exercise and significantly increased when the beta blocker were withdrawn. And thank you.
Thank you, Dr. Sara and Musa, for her informative talk about what is new in the management of heart failure. May I introduce Dr. Huwaida Hashim from the side of Alwali company for a short talk, please.
السلام عليكم. عيدكم مبارك وينعاد عليكم إن شاء الله بالصحة والسلامة. ونسأل الله أن يرفع عنا البلاء والوباء والغلاء أزول يعني. أنا هويدا هاشم، فارماسيست من أعمال الولي الطبية. معلش تكنيكال ايشوز دي كل شيء. تمام. أنا هويدا هاشم، pharmacist من أعمال الولي الطبية. إن شاء الله I'll just be taking not more than 8 minutes of your time. I'll be talking first about Alwali. Alwali is a Sudanese company started since 1992. It's an agent for Troika, an Indian company, Pharma, a Malaysian company, and Bliss, also an Indian company. Today, I'm concerned with Troika. Troika is one of the leading companies in India. It's established itself through imagination and innovation. It's innovating patent technologies such as the microsolvation technology, which is the technology I'll be talking today about in the antiplaque, clopidogrel 75 milligram. Other technologies, which are also patented by Troika, from Troika, is the QPS and the Aquatech. بكم عليكم أكيد الداينابار, diclofenac sodium. It's an injection of diclofenac that is given IV as well as IM. It's done by the Aquatech technology, which is patented from Troika. Also, we have the microsolve, which, as I said, we'll be discussing it later. First, clopidogrel, the mechanism of action is well known for all of you. It inhibits the AVP-induced platelet aggregation. But I would like to take a closer look at the molecule of the clopidogrel. If you can see, the molecule of clopidogrel is very lipophilic. It does not dissolve in water. And that's the main difference between, which creates the main difference between the different brands of clopidogrel in the market. And that's why not any brand of clopidogrel can give us the good antiplatelet activity. And we have to be very careful when prescribing, when prescribing the brands of clopidogrel. Not just that, but also clopidogrel is a prodrug, and it has to be activated by the cytochrome P450, specifically CYP2C19. Around 50% of this of the clopidogrel is metabolized by this enzyme. So we should avoid the concomitant use of drugs that inhibit this enzyme, mainly the proton pump inhibitors, which are major in patients who take a dual antiplatelet therapy to protect them from the gastric acid side effects of aspirin. Now, as I said, that the clopidogrel is lipophilic. So we have to intervene externally to make this molecule more hydrophilic, and it can dissolve in the water media so that it would be absorbed. For any drug to cause its activity, it has to be absorbed first. So Troika, and because it imagines and it innovates, it created the microsolvation technology. As the name indicates, micro means the size of a micron, and solvation is coating with a special solubilizer. So microsolvation is a reduction in the particle size, and then each particle is coated with a special solubilizer. As a basic pharmacokinetic rule for absorption, if you have got a large surface area and good solubility, definitely you're going to enhance the absorption. To prove that antiplat, clopidogrel, micronized clopidogrel 75 milligram, has a good bioavailability. Troika has subjected it to a bioequivalence study. This bioequivalence study, the aim of this bioequivalence study was just to make sure that the bioavailability of antiplat is bioequivalent to that of the originator brand. They compared a single dose bioequivalence of a single dose of clopidogrel 75 milligram to that of the originator in 12 healthy volunteers. The study was designed as a double-blinded, balanced, randomized, single dose, two treatment, 2 period, 2-way crossover, and of course with a washout period between each period 7 days. Because for the clopidogrel to be completely washed out from the body, it needs to take 7 days. During each period, they withdrew samples, and in each sample, they measured 2 main parameters: the area under the curve, which is the total amount that has been absorbed by the body, and the Cmax, which is the maximum concentration following a single dose. If you can notice in this table, in the lower part here, in the numbers, you cannot easily differentiate between the numbers of the Cmax for the antiplat or that for the innovator brand. More or less, they have the same numbers, even for the AUC of the antiplat or the innovator brand. And if you check the 90% confidence interval, it lies between the range, which is 80 to 125% for the AUC and 70 to 143% for the Cmax. And antiplat complies with these predefined values of the confidence interval, 90% confidence interval. To make these numbers clear, you can take a closer look on the diagram. It's not easy to differentiate between the curve of the antiplat and that of the innovator brand. And from here, you conclude that antiplat is bioequivalent to originator brand. So antiplat is a microsolved clopidogrel, 75 milligram, that is bioequivalent to the originator brand. Now we solved the problem of the absorption by the microsolvation. What about the interaction? We have got troipanto. Pantoprazole 40 milligram. It's a time-tested, untrusted proton pump inhibitor with the least drug-drug interactions among the other PPIs, the other alternatives. So pantoprazole as a molecule is acid labile. It's destructed by the stomach acid. So we need to bypass the stomach acidity by adding a coat, a protective coat. So troipanto is not just one coat, it's not just a single coat. It has 2 coats. The first coat is made up of a wax-like material called the shellac, and the second coat is a normal polymer or a normal enteric coat. So now we have got 2 coats covering the pantoprazole until it reaches the small intestine, the main site of absorption, and thereby we increase the bioavailability and hence the efficacy. Troipanto has a bioavailability of 77%. In terms of its interactions, it has the least interactions among the other PPIs. It has no potential to the CYP450 enzymes. It has a very low affinity to that enzymes. And antiplat and troipanto are safe to be used together. In this table, you can see that the pantoprazole has the least interaction potential, whether in inhibition or activation of the cytochrome P450. For any further information about the interaction, you can go for the below links. So troipanto, pantoprazole, 40 milligram, and antiplat microsolved clopidogrel. Again, microsolvation is a reduction in particle size and coating of each particle with a special solubilizer. What makes antiplat different is this technology. And why is it superior to other generics? This technology. It is head-to-head to the originator. It has the least price. It has a lower price, which is in our case in Sudan. We are moving it through a financial crisis. So affordability of the drug became a major, if not one of the main factors behind the treatment selection. We have also got troipanto, pantoprazole, 40 milligram, a time-tested and trusted proton pump inhibitor. It is a double-coated pantoprazole with a bioavailability reaching to 77%, the required bioavailability. If you have any question or comment, as they said at the end of the presentation, I'm welcome to answer any. And thank you. So antiplat and troipanto.
Thank you, Dr. Hoida. May I introduce Dr. Abir from Novartis, please.
Good evening, everyone. Welcome back for the first on-site meeting after the COVID-19 pandemic. First of all, I would like to thank to Dr. Yagoub, Dr. Nisrein, Dr. Sara, and Dr. Hadil Hoida for their informative presentation. Second, it's my pleasure, or it's our pleasure to be with you today. Me, Abir Ahmed, Medical Science Liaison for Cardiometabolic Line, English East Africa or Sub-Saharan Africa. Join with me today, Dr. Mohammed Ahmed Babikir, Medical Science Liaison for Communicable Disease, and Dr. Mohammed Badani, Medical Advisor. Third, I will not take more than 5 minutes to just take you or to summarize and take you through the journey of change. As you see in this slide, this is the evolution of heart failure therapy. And you can see that from early 1980, when we start with digoxin, throughout the innovation of ACE inhibitor vasodilators such as hydralazine, and through nitrates, beta blockers, until we reach 2005 with ARB. So since 2005 till 2015, there is no any medication in this era of heart failure with reduced ejection fraction. And still the mortality in heart failure with reduced ejection fraction is still remain high despite several therapy that I mentioned before to improve the survival rate. So the survival rate in chronic heart failure improved with the use of therapeutic intervention that target either the renin-angiotensin system or sympathetic nervous system. And although of all of that, 50% of all heart failure with reduced ejection fraction will die through 5 years of diagnosis. And this is just the scheme of how the drug reduces the mortality. And so, as I told you, till 2015, there is no new medication. So here we come with renin-angiotensin neprilysin inhibitor, reuptake inhibitor, which is substitute of ACE inhibitor, and that results in further reduction in mortality and in morbidity. To move on and see. As you can see, and all you are witnesses for the journey of heart failure with reduced ejection fraction patient, starting from first diagnosed, the newly diagnosed patient, then the patient came to the clinic as chronic heart failure with reduced ejection fraction patient, and unfortunately there is a hospitalized patient. And all these categories are interact with each other, the newly diagnosed is chronic or from newly diagnosed to just hospitalized. And for that, Novartis start the first and the large study, which is paradigm heart failure study for heart failure with reduced ejection fraction, which is the paradigm heart failure, and the study is continue through evaluate heart failure. We have pioneer heart failure, transitions, proof heart failure, and titration. All of these trials are cover the journey of patient from newly diagnosed to hospitalized. As we can see here, from 2014, we start with paradigm heart failure, which state that ARNI, which is sacubitril valsartan, will reduce the mortality and morbidity by 20% reduction in comparison with enalapril. And we can emphasize that 20% reduction in cardiovascular death and 21% reduction in hospitalization. And when we come to all cause of mortality, sacubitril valsartan reduced that by 16% and 20% for sudden death. Then we move to titration 2016, which stated that for all patients that take sacubitril valsartan from 50 milligram to 200 milligram, which is the target dose, you can start the titrations and reach the target dose through 3 to 6 weeks from the beginning. And this for chronic or stable, are not really stable heart failure with reduced ejection fraction patient. Then we come to European Society of Cardiology, which in 2016, and they said that ARNI substitution for ACE inhibitor and ARB. Then we move to 2018, we come with transition. Here we go. We move to see what sacubitril valsartan can do for hospitalized patient or early heart failure with reduced ejection fraction patient after discharge. And they stated that when you start sacubitril valsartan for those type of patient, hospitalized patient, or immediately after discharge, you can see a huge reduction in NT-proBNP, which will reflect in high improvement in quality of life. And then we have Pioneer to see what happened when we start sacubitril valsartan on highly risk subgroup, like the de novo patient, which are the newly diagnosed patient. We start the journey from the beginning, and the naive patient, this patient who did not take any medication like ACE, ARB, beta blocker, or etc. And they proved that when you initiate sacubitril valsartan for this subgroup of patient, the de novo or naive patient, you have greater much reduction in NT-proBNP, which will reflect in the improvement in quality of life and reduce the morbidity and mortality. And we come to the most important study, which is Proof Heart Failure 2019. And they state that the sacubitril valsartan improved the quality of life and reduced the mortality and morbidity because they just change all the echocardiogram parameter. We can start from left ventricular ejection fraction. They stated that there is increased ejection fraction from baseline. It can reach in the mean of 13% increase in ejection fraction. They change in all LV function, LV end diastolic volume, LV atrium volume, LV end systolic volume, and that which reflect the reverse cardiac remodeling. And they see how this remodeling happened with Evaluate Heart Failure Trial in 2019. And then we move to 2020, when the expert consistent decision pathway state that you can start sacubitril valsartan immediately for heart failure with reduced ejection fraction. And here we go when we reach the updated guidelines, European Society of Cardiology 2021, which happened in June 29/6 تقريبا. And they state that clearly, this is the European Society of Cardiology Heart Failure Guideline 2021 Management of Heart Failure with Reduced Ejection Fraction. You can start ARNI for all type of patient. You can add beta blocker, MRA, and SGLT2, like Dr. Sara said. So you can have a quick view of these guidelines. This is more clear here. You can start with ARNI, add beta blocker, MRA, dapagliflozin, and loop diuretics for this patient, and you can just follow the diagram. And for that, I can end my presentation. Thank you for joining us today. And yeah, it's very good. And thank you. Now I think the discussion, commitment, and any concern is open for all the presentation.
Okay, thank you, all the presenters. Thank you for the host for their brief, elegant presentations. I think it's time for questions and interactions with the speakers. If there's any question from the floor, we'll take it and convey it to the speakers. Or I could take the pleasure and ask Dr. Yagoub if he's still there. That's about titration in hospital. We're facing a lot of patients in clinical practice, patients coming from far away, from far distant, different towns in Sudan, coming, for example, to sharp teaching hospitals. And we start heart failure treatment. From my observation that we discharge them for optimization outside the hospitals, and we don't have these facility of optimization or follow-up outside the hospital in district hospitals or in far hospital like Al-Fashir or far in Sinnar or Dongola or wherever in Sudan. I feel if we commit ourselves to fully optimize this patient in-house before discharge, that will relieve the burden of the district hospitals, and at the same time, this will reduce the optimization, the incidence of rehospitalization. And if it happens, the rehospitalization, it will reduce the length of stay in hospital, what is called the LOS length of stay in hospital, because if the patient is fully optimized, you could just deal with the offload and see what's the precipitating factor, deal with it, and if need further optimization, you could do it in a short period of time and discharge the patient. Just I want to shed a light, if somebody could shed a light about this, because in the studies he presented, there's a large number of hospital of readmission, and I think the most important factor in my experience in a shop hospital is that patient coming from far outside Khartoum, they are not fully optimized in the hospital. They discharge and they come back because nobody will touch them outside Khartoum or touch their medication. They leave them on whatever you start, and they come, and sure they will compensate shortly and come back. Thank you. First question for Yagoub. Yagoub is not there. Okay, sorry. Okay, I think this, you could take it as a remark. What I do in my practice, every patient with heart failure outside Khartoum has to be full optimized. Everybody work with me as a fellow or a registrar, they know this. We full optimize the patient, maximum tolerating dose or reaching the target dose of the three components, mainly the three components of disease-modifying drugs, S or ARNI and or ARP, beta blocker, and mineralocorticoid receptor blocker agents. That's what we do usually, and we find that in my unit that reduce the recurrence of hospitalization a lot. This is one, and then we keep if anybody have question, and just one question for Nisrein also. That's if you have a heart failure clinic, what you need to have is to have a heart failure team that will see the patient on presentation, and that will deal with the patient from the start. The heart failure team should deal with heart failure patient regardless of the name of the units. If heart failure should come early in the morning to the ER or wherever the patient are, and assess them regardless of their units or not their units. And that's what will do two things. That will first of all reduce the length of stay in hospital, the LOS, optimize the treatment, the ensure optimization of treatment, and at the same time, send them back, guide them to the heart failure unit or the heart failure multidisciplinary team, and this will be a good substrate for research. Heart failure units is a invaluable source of research. I work in 3 heart failure units in my life, and when they want to do a research in anything, it takes them 5 minutes, and they publish the paper next month because the data is there. Just is in the database, they enroll it. I give you an example. When you mentioned, Sara mentioned the management of iron therapy in heart failure, the first big trial called the FAIR-HF. They asked our unit to do the pilot study. We did it in 5 minutes. 5 minutes. We adjust it in an hour, we submit it back to the team and they got it. That's it. And then from this, they built a huge study. It's okay. So heart failure units is invaluable for the management, for the mortality, for the benefit. And it's easy. It is a nurse-led unit. You just need to teach nurses. You could address this with the nurses with some university. They could get degrees in heart failures. They could become professors in heart failures. And at the same time, this will make a lot of paradigm shift in our thinking, a paradigm shift in our outcome of heart failure patients. Nisrein, if you have a question, come. Oh.
هو تعقيب على كلامك يا دكتورة صادق in to how to deal with the patients who are coming from far away from the states and from the far states. It's a practice that has been نعم. Okay. Okay. هو تعقيب على كلام الدكتور صادق يعني في in how to deal with the patients who are coming far away from the states, from the far states also. يعني هنا after يعني in Khartoum you can achieve it either through hospital admission by long stay or by preparing the patients for optimization while they are in the hospital or through clinics. But those who are in the far states, really what could be done, and it has been done and showed really achievement. The last year there were training courses for doctors, the first line doctors, especially for STEMIs and acute coronary syndromes. Really, we saw the results of these courses. We used to have patients coming from the far states and they are well managed and thrombolized and receive the initial therapy properly. ما زي زمان patients بيجوا and they have missed MI and missed STEMI. Really, this showed an effect. In the same way, we can do the same practice and teach doctors in the peripheries and also in the far states and to come and we can leave the priority for them and to come and to have courses and training in heart failure program and in optimization of medication. Because from our practice, when we try to seek these doctors who are far away and to talk to them and to explain to them the up titration process, you can still find that there is fear in these doctors to do this. Usually when we were not cardiologists and when we were not cardiac fellows and registrars, usually we had the fear from treating arrhythmias, treating STEMI patients, giving thrombolysis. But when you go into the program, you find it is easy and it's achievable. So in the same way, you can titrate these doctors, you can desensitize them from the fear of up titration process and the fear of renal impairment and the fear of hypotension by giving them these doses, by training these doctors that it can be achieved. You can up titrate the patient with close control of the blood pressure and the close control of his renal profile. And actually the renal profile can improve with the process of up titration. With this process, we can deal with our problem. We can educate the doctors through courses and we can achieve good achievement of heart failure control among the far states because it is really quite prevalent, especially in the far states.
It's okay. The floor is open for questions. Come on. Just tell your name and give your question.
Assalamu alaikum. My name is Summer and I'm a pharmacist. I used to work as a product manager at Alwali Medical Enterprises. So I have a question for Dr. Yagoub. If I remember correctly, in the first presentation, he has mentioned that around one third, which is almost 30% of rehospitalization is caused by non-compliance to the medication. So I have a question. Was there any effort to investigate the cause of this non-compliance to the medication?
Yes, I answered it on behalf of Dr. Yagoub, but I think we used to have a problem with this compliance in our hospital in the shop, and it's far much improved when we hire clinical specialist pharmacists, which they spend a lot of time. They are in the floor and they concentrate mainly. We have a floor for heart failure patients, and have one girl, one of the pharmacists is just dedicated to that floor, just to reduce this common problem of incompliance of medication, and the significance of the medication to the patients themselves. Sometimes they feel that they just prescribe them for a month and that's it. And then the clinical nurse specialists, they make a big difference in our practice. Is there any question in the floor? Abdullah, come on.
What I will ask about patient self-monitoring and how they adjust the growth.
Okay, Nisrein, this is a question for you about patient self-monitoring.
Yes.
If you could answer this, please.
Yes. This is okay. Self-monitoring of the patients really is one of the main domains of the clinic, and that is to educate the patient about their condition and about self-monitoring. And this is clearly explained here in the patient information leaflet. And it is the role of the patient, of the nurse, the nurse trained in heart failure program, to educate the patient about their condition and about self-monitoring, their symptoms, their diuretic doses, and when to feel there is worsening their symptoms, if they had more water, intake of water, if they had more intake of salt. And especially in this patient information booklet, we had في النهاية at the end, we have tables for weight, and that this one of the indications for the patient that he knows how his condition is improving or is worsening. So it's a process of education. And the education is one of the very important markers of the clinic to education patient about their condition, the causes of decompensation and improvement. So self-monitoring is one of the main domains of the clinic, and through education process, mainly in the leaflet and through the nurse and through the team. It should be well achieved. أهم حاجة في clinical self-monitoring. Did I answer your question? Okay.
You know, the area of monitoring is very interesting because we are now talking here about self-patient monitoring, and people outside the world talking about what's called remote monitoring. Remote monitoring now is a function of the cardiac units. You have one nurse sitting in front of a computer every morning. She will have the data of her patient, the 250 patients. She will have them in 10 minutes in front of her. Their weight, their BMB this today, their bioimpedance. They just gave them a weighing scale, a telephone that could be used, and they put it beside them, 1 meter beside them, not farther than 1 meter. That will check the humidity of their breath. They call the bioimpedance, and it's reflected in a graph for the nurse with the weight and the BMB. And the nurse in the morning, if she finds anything different in two of them, the weight is up, the bioimpedance is up, she will call the guy or the guy, Mrs., what's happening to you? You miss your tablets, you take extra fluid, do you feel symptoms? Just take extra diuretic today, and then we'll see what's going tomorrow. Because the aim of the heart failure unit is to keep the patient outside the hospital. This was what called remote monitoring. But did we reach that time? Probably our grandsons might do that one day here in Sudan.
Assalamu alaikum. We have this question for Dr. Elsidig in the chat books. How can we balance between the titrating medication before discharge and to keep minimum titrating period of 2 weeks as directed by the guidelines?
Yes, I got the question. Dr. Nafis is just asking that, how can we titrate the patient in a short period of time in hospital? Again, it's the time of titration with the guideline every 2 weeks. In hospital is different. Titration of 2 weeks is for outside patients. In hospital, you see the patient every day. Every other day, you come to the patient, you start, first of all, you start your ACE or ARNI in a smaller dose, and then you start titrating. Titrating, you are governed by few parameters. Talking about ARNI or ACE, you are governed with blood pressure, systolic more than 90, and creatinine less than 2.5, and potassium less than 5.5. You could check this every other day. Okay, every other day, and you titrate, and you wait for another day and check, and every other day you titrate. You keep the patient for extra 10 days, you keep him out of the hospital for the rest of his life. So when you discharge the patient with fully optimized, with the maximum tolerating dose, or with the guideline directed target doses, that will help the patient, will keep them outside the hospital, and that will relieve the burden for the collapsing health system of our country. You could, yes, yeah, I know. So that's what you need to do every other day. This is governed. If you're talking about the beta blocker, you're governed by blood pressure, systolic more than 90 at any time, and a resting heart rate more than 70. You could just increasing the dose to the target doses. You're talking about MRA, you're just talking about blood pressure more than 90, creatinine less than 2.5, and a potassium less than 5.5. And by the way, you don't need to afraid about potassium. There's a lot of phobia about potassium. Potassium is a very nice thing for heart failure. When you have the 5.5, when the potassium is more than 5, this will have a negative feedback on the aldosterone axis. It acts as if you are adding aldosterone. So it helps the patient to suppress fluid retention. Potassium is a very nice. أنا لما ألقى الريجسترار في الراوند يقول لي البوتاسيوم 5.5 أقول لك أنا في زغرته وتعالي. That is good for the patient. لكن unfortunately الريجسترار بيجي جداد يلقوا البوتاسيوم 5.5 all the night دكستروز سلاين ما تعرف انسولين والفول يقول لك بقى كم والصباح بقى كم يا بوس والله كان 5 ونص الليل عملنا 4. This is what called a very good unnecessary job. Okay, potassium is very nice for the patient. As far as less than 6. You don't need to be afraid about it. You can titrate as far as 5.5. You could increase the dose of ARNI, you could increase the dose of ACE, you could increase the dose of potassium sparing diuretics. Okay. In terms of beta blocker, there's a dilemma in dealing with beta blocker. Beta blockers, if the patient come off loaded or in pulmonary edema, when he is taking beta blocker, you don't need to stop beta blocker. And at the same time, you don't need to start beta blocker. All you need is to offload the patient. And when the patient is euvolemic, you start titrating the beta blocker if he's in smaller dose, or to start it if he's not taking it at all. And then governed by the parameters of the guideline of the consensus agreement among cardiologists how to titrate beta blockers. So beta blockers, if the patient in pulmonary edema, don't stop it. This is a wrong practice. And don't start it unless the patient is euvolemic, and start titrating after that. Any question? Yeah, it's not only for the potassium. It's for all disease-modifying drugs. In heart failure, when you face with high creatinine or high potassium, look for other causes other than those drugs. For example, if you find the patient have a creatinine of 3, and he's taking ACE or ARNI. ACE of ARNI is very important for a patient with heart failure with reduced ejection fraction. Try to look for other reasons. Overhydration, reduce the diuretic dose. Probably he's taking high dose of mineralocorticoid receptor inhibitors. Probably he's taking non-steroidal anti-inflammatory. Don't rush and touch the RNA or ACE inhibitors. Look for other causes. The same for potassium, the same for beta blockers. These are disease-modifying drugs, and they're invaluable benefit for the patients. What you do at the bedside is what is mentioned not mentioned in the guidelines. This is what you learn at the bedside. Don't touch it. Look for other causes and try to correct it. This, in terms of all disease-modifying drugs, and in potassium also in particular. Yeah, it's usually the renal function goes initially up, it goes down. The renal function in practice usually don't goes up to 3.1 without any major cause. So up to 3.1 you are safe, and you wait it could come down. When it is 3.1 and above, just you need to step back and see if there's other causes worsening the renal function and try to deal with that. Other molecules, overhydration, you excessively overhydrate the patient or overdiurese the patient. And these are the common causes of the bedside. And if you patience enough, a day or two will solve the problem. Yeah, the cardiologist syndrome. There's three subsets or three subclasses of cardiologist syndrome. Class 4 was merely a venous congestion. The nephron are congested, the same like the legs, the stomach, the same like the lungs. It's congested. When you offload the body, you offload the nephron with them. The function will improve with it. Okay, so you don't need to worry. You usually just wait, and this usually happens. If it is class 4 or subclass 4 of cardiologist syndrome, usually is no problem. The problem is if it is arterial problem, that's sometimes things get worse. But usually the venous congestion usually get better. I have a small point about the BMB, because in the definition, the American definition of heart failure is you need to confirm it. Still, heart failure is a clinical diagnosis based on symptoms, signs, and you need to look for functional and structural by investigations. But the use of the BMB is always sometimes misleading. BMB in chronic heart failure patient is different from acute failure presentation. So it's the level, interpretation of the level are not the same. If the patient in chronic heart failure and presented with decompensation, the BMB, what you are looking for is not the same like in the acute form, in the first one. Like the level in the chronic form is 300, in the acute form is only 100. Is the pro BMB. In the BMB is 100, in the acute form is 335. So you need to look at this. And there's something called the discharge BMB. Like BMB is used for monitoring treatment and prognostic values and for helping you to understand your patient. So if you did the BMB on admission, this would give you an indication of prognosis. The higher BMB is a bad prognosis. The lower BMB is a good prognosis. But if you have to do it on discharge, because this will tell you what you have done. Your intervention is right or not. The patient stay with you in hospital for 10 days. If the BMB is the same like admission BMB, you haven't done enough, most likely. But if the patient become euvolemic and bordering around and back to his baseline of activity and his BMB is still high, this is called the discharge BMB. The discharge BMB should be documented, because if the patient came back again, you compare everything to the discharge BMB, not to the BMB in your mind mentioned in the guidelines. Consider this as a baseline. So let us give an example. I have a patient come to me with 3,000 BMB, stayed with me for 10 days. We did our best for that patient. He became very well, watering around, funny, doing his things and back to his normal activity. But his BMB is 400. If he came back again with BMB 350, this doesn't need to be admission. This wouldn't be heart failure, although it is above the range of the guidelines. So you need to keep this in your mind in practice. So BMB, you have to use it right. If you manage to do an admission BMB, please do a discharge one and document it, because that will be his baseline BMB, and that will be the BMB for the patient. Okay. Another point about the SGL2 and diabetes, because diabetes is a big problem in heart failure. It's the biggest problem in heart failure, because diabetes, first of all, double the mortalities. If the patient diabetic and get heart failure, his mortality is double compared with a normal DCM, non-diabetic one. Diabetes affect the small arterioles We know that in the coronary bed, 95% are small capillaries. Yet where diabetes affect them. Don't affect the big arteries alone, affect the smaller arterioles and the capillaries. So affected probably 80% of the coronary bed. That's why heart failure with diabetes is as worse as ischemic cardiomyopathy. You have to take this because diabetes is always a problem, which you should give a special attention to patients with diabetes and heart failure. Thank you. Okay, we're talking about the co-chairman. If there's no question, we conclude this. We have one question there on the floor. Come down.
Assalamu alaikum. Good evening for everybody. Thank you very much for all presenters. My questions, or first, I am Dr. Yasin, I am cardiology fellow. My question to Dr. Sara or Dr. Abir. Nowadays, we see many patients. They are young patients with heart failure and reduced ejection fraction. If you assume you have a patient with heart failure and reduced ejection fraction was 38. And we put him on the standard medication according to the guidelines. What I remember that the ARNI or this Interventional during 1 year, it may increase the ejection fraction up to 13%. So if you have a patient with 38 ejection fraction, after 1 month it became 51. So by definition, ejection fraction of 51, that the patient has heart failure with preserved ejection fraction. For me, my question, for like these young people with heart failure reduced ejection fraction, these medications are lifelong, or we have a certain point you can stop the interest.
Actually, patients with reduced ejection fraction and ischemic cardiomyopathy or non-ischemic cardiomyopathy, and they have reduced ejection fraction, when you give guideline-directed medical therapy and the ejection fraction back to the normal, are you going to stop or not? They did the study and they found that if the patient is stopped from the medication after 6 months, they will come back with a symptom of heart failure. So it is better to continue with medications. Lifelong.
I think it would be very good if you can relate that to reverse cardiac remodeling and cardiac compartments in general. يعني كانت very evident to heart failure study. I think this would originate the study. Yes.
It's well known that through the spectrum of all types of heart failure with different etiologies, even postpartum cardiomyopathy, there is 30% to 40% chance that when you stop medication, the patient will go back to reduce LV function. So try not to stop that. You could modulate the medication. Modulate the medication by what? If the patient becomes asymptomatic, he doesn't need mineralocorticoid receptor blocker agents. Doesn't need spironolactone and the like, and ibuprofen. But the ACE and the beta blocker, they have to be there for life. You modulate, but you don't stop. You got the idea? Nisrein, you have to add anything?
Usually I have young females, and they had they are very young, but then give them the titration process and they improve and they get back to normal. When still they are young, but they're young, they should also give birth. Really, I struggle with this dilemma.
No, you stop medication, you have 30 to 40% chance. In some studies, 40%. The 3 or 4 studies, they stuck to 30. So especially even there's a recent consensus in JAC about postpartum cardiomyopathy patients. Yes, you don't need to stop the treatment. There's 30% chance in this group of postpartum cardiomyopathy, they shift back to to the risk of the risk of the new pregnancy is huge for each patient with peripartum cardiomyopathy, postpartum or peripartum cardiomyopathy, and you don't need to stop the treatment. You could modulate the treatment. You could stop the mineralocorticoid. This is consensus agreement among all the cardiologists. But the ACE and the beta blocker, there's a lot, or the ARNI in general, or ACE or ARP, and the beta blocker, you should just keep the patient on this medication and follow up. I have few of them here in Sudan. No question, just ACE and beta blocker. They come every year, we do the same, don't stop medication, don't stop medication, that's it. No, dangerous, no way. Okay, heart failure, there's just few interesting things about in heart failure. First of all, is one of the ancient diseases described in literature. If any one of you visit Acropolis in Greece, go and visit the statue of Hippocrates with Sister Polydas. Sister Polydas was a lady presented 2,000 years ago with ophthalmia and paroxysmal nocturnal dyspnea. It's written in the statue. This lady presented in Greece paroxysmal nocturnal dyspnea and cough, and that was 2,000 years ago. So this is one of the privilege about heart failure. The first disease described in medicine, one of the first described in medicine, approved with a statue in Acropolis Museum in Greece. And at the same time, the area of evidence-based medicine is one of the first diseases that have the trials, when the trials done without females, the consensus trials, in analabril trials done without females, because the church wasn't agreed at that time. In early 80s, that's the females will go into trials in medication. They don't know what's going to happen to them. To conclude, if you have our friend, Dr. Awad, if he's here, want to add? Okay, we conclude with that. Thank you very much for Sudan Heart Society, Alwali. Anti-blood? This is not heart failure. Yeah, sure, thank you. Thank you. Thank you very much. Thanks, everybody.
Invite them to the dinner. Invite them for the dinner.
Yes, everyone, we can now go for dinner, please.